You know, I have to start off with saying that picture of Sound of Music, you know, that's like my family. Since I have 7 daughters, we've had 2 boys, and so we're kind of like that. We kind of, you know, go through the mountains in Utah, but there's always challenges behind those happy faces as well. Surgical care for a better world. I'd like to start off with this is one of my favorite quotes from Lao Tzu, Chinese philosopher. Go to the people, live with them, learn from them, start with what they know, build with what they have. Haven't we heard that today in the conference? But with the best leaders, when the work is done, the task accomplished, the people will say, we have done this ourselves. And I was asked to come speak in a conference in Hawaii recently to talk about why I do this kind of work. And I had to really sit down and think, not only why did I do it, where did I get some of the basic tenets that I've used in my global surgery work? And I hope you can bear with me as I tell you a little bit about where some of this began. So if any of you have seen the Book of Mormon musical, it's not quite like that. But I was an LDS missionary in Thailand from 1978 to 1980. And over there, had many experiences that set a foundation that I use, I think, through my work both here in the United States as well as abroad. Because I was able to work not only in teaching Christianity, but in building ditches when the monsoons came and was washing away the chicken farm, working with families and their challenges, working out in the hayfields, and learned a totally different culture and a different religion with Thai Buddhism. And one of the things that I was asked to do, I was called to go up to Ubon. And my call for up there for 7 months of my 2 years was initially going to be the branch president of the local congregation in Ubon, struggling little branch. And a week before I was supposed to take over, my mission president called and said, would you, instead of being the branch president, will you please be the first counselor and train the first Thai person to be the leader of the local congregation? Now, I was 19, 20 years old. I got a manual, and it was certainly a learning experience for me. This is President Bunya Said and his family. His home was off to the left, up on stilts, a wooden home. And so in terms of our little struggling branch was very interesting because we spent 7 months trying to teach him how to be the leader of a branch while I was learning how to be a leader in truly sustainable development. How do you build something that's going to last after you're gone? You know, he lived in that little wooden house, and as missionaries, we lived in this kind of nice home on the 2nd floor. The 1st floor was our little made-up chapel, and this is our little small congregation at the time. Well, that's how most bonfires began, as a simple spark. And I listened to a lot of what the medical students and the residents are doing right now. And I would say, don't take for granted what you are doing right now and how those things are going to help you in the future in what you are doing. For in 2015, this was the notice that I got. Gambrachum Yai Tongtin, Nai Ubon, the Ubon District Conference. Puajatang Satek Hang Tisam, Nai Bratay Tai. Sungtaben Satek Hang Rag, Nai Pagisan. This is the first stake. This is a large congregation, not a little branch. It's a stake that represents probably 7 or 8 large congregations that then come together. And so in terms of sustainable development, did I have anything to do with this small little branch, training the first Thai person to be the branch president? Because there's never been a foreigner that's been the branch president since. But they built it themselves. What is the little spark that we develop in our global surgery work that really goes on further to develop sustainable healthcare? So that when I applied to medical school, this I found I never throw anything away. And I've got one of my classmates with here, Laura Torres. This is one of my personal statement. Learning of the medical, social, economic, political, and emotional problems of the Thai and Laotian people, because I was up in the northeast of Thailand, where there's a refugee camp of 40,000 at the time, increased my awareness of my own desire to be able to put myself in a position to serve mankind. And I hadn't realized how important that really is. As you just heard here, how do you put yourself in a position to do what you want to do? This is Brother Kuhn. His family was kicked out of their home. We weren't sure what to do. But the people there knew what to do, and they showed me how to cut down the bamboo, and they showed us how we can go ahead and build them a home for the parents and their 6 children in this two hut, home. So what do you want to do? You want to follow your passion. And what is a passion? According to Wikipedia, that knows everything, it's an intense driving or overmastering feeling or conviction. It's a strong liking or desire for a devotion to some activity, object, or concept. This is the hospital I work at. I work at both the University of Utah, but this is Intermountain Healthcare. What is the passion? And I would say my passion about this work for my entire life has been actually more of a mission to help people live healthier and more meaningful lives, to relieve suffering, and to overcome disparities in accessing surgical care. And obviously, I can't do the numbering right. So, but in global surgery, we learn to adapt and overcome. But these are the things that I have a mission in life. It's not just a job. If it's just a job, the $2 million I've lost in income over the last 15 years, I could think about that. But it's not. It's a mission to help others in any way that we possibly can. I was actually speaking at a donor group at the University of Utah recently. And at the end of it, there's a question and answer period. And one of the people raised their hands and they asked, what do you do when things are overwhelming? I'm going to get to that in just a minute. So in terms of what we do as our passions, in about 1.5 years ago, at the American College of Surgeons, the group of us that were the authors of the Rural Trauma Team Development course went out to dinner. There was a lot of discussion about burnout. And we sat around the table and everybody said they were burned out and wanted to retire. They all love taking care of patients. And I said, well, this is a problem. How do we encourage people to go into this, and how do we encourage ourselves? And one of the surgeons raised his hand, well, didn't raise. He said, I have this file, and I have this file of thank you notes from all my patients. And I go to that file and pull out a thank you note, and I read it, and I say, yep, I remember why I went into this, and I keep going on. And I can get through that medical record, and I get through all the other hassles that we're dealing with right now. Last year in January, I had my shoulder operated on, so I brought home my big file of thank you notes, and I'm going to share a couple of these with you. Last November 6th, you performed an appendectomy on me. I was 8.5 weeks pregnant. Little Carrie was born June 27th. She weighed 8 pounds, 7 ounces, and was 22 inches long. She just had her 2-week checkup and is in great health. I'm so appreciative of the care you gave me. I feel great, and thank you. Now, isn't this wonderful, the kind of care that we can give and the thank you that we get? But when we look around the world, we find a lot of people that don't even have the opportunity to send a thank you note. We have 18 million people that are dying each year as a result of surgically treatable conditions, whether or not it's a meningocele that could be simply treated, some trauma that's been inappropriately taken care of, or like the patient in the middle that is not from sub-Saharan Africa or Southeast Asia, but showed up in my office in Salt Lake City. Inguinal hernia. Another thank you note. Dr. Price, last fall, after recovering from surgery and several infections and the effects of 2 treatments of chemotherapy, I felt lost and almost hopeless. I was preparing to die. She goes on to describe how she felt like she was in the middle of a lake, alone on a boat, and that she could see the shoreline, but she had no way to get there and nobody to help her to get there. The feelings may be very similar to how many cancer patients feel, alone, frightened, and isolated with no lifeline, no secure hold on anything tangible. I've had a great deal of love, support, and encouragement from many sources, but there have been very few individuals who have been able to help me see the shoreline as something I can reach. Few who have been able to give me any secure feelings, any real hope. To you, any known form of appreciation doesn't seem enough to cover my gratitude for all that you have provided me. Yet I feel a strong desire to say thank you for giving me so much. Thank you for helping me feel as though I can reach the shore. Why did you go into medicine? Haven't we all gone into medicine to try to help our patients reach the shore, to have some hope that they can reach that? There are a lot of patients with cancer out there that don't have that lifeline, that they're presenting with stage 3 and 4 breast cancer or massive sarcomas that nobody can take care of. We know the data that in high-income countries, the ratio of mortality income is much lower than it is for all solid tumors in developing countries. How is it that we can go ahead and be that lifeline? Well, I mentioned that I got this question: how do you not get overwhelmed with the scale of the problem? And we've talked about huge problems. How do we not become overwhelmed and keep moving forward? This is our work in Haiti, as I directed the disaster team for the LDS Church for the first few weeks. And it was overwhelming. What do we do to move forward? I answered, you start small and do a little at a time. You find like-minded partners, and then you always keep trying. And I'm going to talk about these 3 areas for the rest of my time and see if we can't point out a few ways and people who have really done this well. First of all, Glenn mentioned Dr. Rodas, who is a good friend of mine as well. And I have to mention, Glenn really was wonderful. He's one of the early ones, the American College of Surgeons, speaking in the early 2000s on his work before it was really recognized at the American College of Surgeons. Dr. Rodas was previously the Minister of Health in Ecuador. And for many years, he visited remote areas of Ecuador by plane, donkey, foot, and he organized teams of volunteers throughout the area. He didn't start off just with surgery. In fact, he was trying to teach clean water and sanitation and so many other things. But he said, you know, Ray, people aren't listening to me very much. And so I had to do something a little different. And I saw all these diseases people had. And so that's when he developed his surgical truck, probably about 25 years ago now, almost maybe 30, that he then drives to all the different provinces throughout Ecuador. And one of the things he told me, he says, Ray, you have to be careful. You have to not let people tell you it can't be done. We had gone and we had visited a village. We had all the people ready for surgery. And then we realized we couldn't get our truck there. It was too tall and the mountain was overhanging the road. And his wife said, well, don't you know all the mayors of the country? He said, yeah. So his wife said, well, why don't you call him and ask him to blow up the mountain? So he did. And they blew up that part of the mountain. He says, see, so there's always a way. I would encourage us to blow up the mountains that get in our way when people tell us that it can't be done. Because what he did is not only show the effects of surgery on the community. There's not a lot of data. We did an article from the World Health Organization trying to look up how surgery strengthens health systems. And we found there's no articles. It's a great area for research that we really need a lot of work on. How does surgery improve the health system? How does it strengthen the health system? Well, here's one example, that when he brought his surgical truck, he says, all of a sudden people started to listen to my other programs. And he took the malnutrition rate of 1-year-olds in Santa Ana from 2002 to 2005 from 47% down to 8%. So surgery can actually pave way for the integration of other healthcare interventions. He also then began the Integral Family Health Program that included growth and development, malnutrition, medical care, reproductive health, elderly and handicapped care, oral health, all sorts of different areas to improve the healthcare. And he said, they saw when I brought the truck and we fixed a hernia where somebody was out of work for 10 years, and within 3 weeks they were back to work, they started to listen to what we were saying. What can surgery do for the community? It's not just about the procedure itself. So here's somebody who started small, began doing simple things, and has had a major impact on his country's healthcare. He also built an operating room houseboat. He got $1 million from the country of Colombia down in the Amazon. That's where I went to work with him. Unfortunately, the government didn't keep up with their promises to keep that boat up, and it's not functioning right now. So there are challenges. So find like-minded partners. You know, as we look at partners, sometimes it's not partners. Sometimes they're collaborators, or it's an alliance or an association. but find people that have like-minded ideas, because that's how things grow. And that's what is so impressive about coming down here to Houston, to see like-minded partners making something greater than they could do on their own. It's really exciting. So I was invited to go over to Mongolia and to teach trauma. I was on the National Committee on Trauma for about 20 years. In fact, I jump over to San Antonio tonight to meet my Mongolian coordinator, who's coming for the first time for the Advanced Trauma Life Support International meeting. And when I was first invited to go to Mongolia as a patient of mine, he said, you know, you're working in Ethiopia and some other places. Why don't you come to Mongolia? We're donating equipment to 39 different hospitals and they don't know how to use it. Can you come and provide some training? I said, no, it's too cold there. My parents used to threaten to send me there if I misbehaved. Why would I want to go there? I want to go to Thailand. And he said, we'll be in Mongolia for 1 more year, and then we're going to Cambodia. We've talked to the Prince of Cambodia, and we're going to move our work down there. And I thought, ding, I'm going to get in on the ground level, and I'll be all ready for Southeast Asia. I'm still stuck in Mongolia 12 years later, but it's a beautiful country. So first went there thinking, what do they need? Well, as I got there, I went, well, they're obviously going to need training. This is my first thing. I asked the resident there, show me how you put in your chest tube. Anybody know, is this the right way to put in a chest tube? No, I called him Chinggis Khan after that. And so training, equipment, all sorts of things, but you start where they're at and then you move from there. But there wasn't a real buy-in on the trauma. So after spending almost 2 weeks there, I was invited over to the university where I met Dr. Segerlin. She was the chief of surgery and has become, in my mind, one of the smartest women I've ever met. She gave me this PowerPoint talk telling me about how laparoscopy was introduced in Mongolia. And she told me that Dr. Buck Rusher back in 1994, a guy from Arkansas or Alabama, came over and trained some of the surgeons and anesthesiologists. Dr. Gonbold here, who is one of our commissioners on the Lancet Commission on Global Surgery, was in on this. They brought people over here to the United States. They trained them. They went back. They did the first laparoscopic cholecystectomy. They went out to dinner. They all got food poisoning, and Dr. Okandaya died. So there are some challenges with global surgery, and we have to be careful. By 2005, she said only 2% of the gallbladder surgeries were being performed laparoscopically, and only in the capital city of Ulaanbaatar. And she said introduction and further development of laparoscopic surgery in Mongolian surgical practice is demanded. That's when I thought she was the craziest lady I've ever met, because I really came with the idea that we need to be teaching basic and emergency surgical care. And I came to find out that she was already beginning that. She had partnered with the World Health Organization with the Global Initiative for Emergency Essential Surgical Care. The manual was published in 2004 and 2005. They began their countrywide plan to be able to take this throughout Mongolia. This was the first coordinated effort to address the absence of adequate capacity for emergency and essential surgical care services in low and middle income countries. Now, I want you to notice something that Dr. Segerlin is already doing, because this is addressing surgery, anesthesia, obstetrics, orthopedics. It was targeting rural hospitals, district hospitals, primary healthcare facilities, and health centers. But what was she doing? She was finding like-minded partners. Okay, she knew what she wanted, and she was really looking for people to help accomplish what she needed in her country. So they did this countrywide project where she really initiated, and this is Dr. Gonbold again and Dr. Segerlin, teaching this emergency essential surgical care course across the country. And I was able to be involved when we then went back and looked 2 years after the whole project to see if the information is staying, and found that with this project from 2004 to 2012, they had significant improvements in many areas. Now, there's some areas that really didn't improve. They were really more highly technical than could be done at some of these very small health outposts. But in many of the areas, the establishment of an emergency room that was functional, their emergency room kits, the recording of emergency room cases, and instructions on facility and instrument usage had all dramatically improved based on this course and was staying in these areas. So not only was she looking for partners began to work with her to document what she was doing. And Mongolia became an example for the world of what this global initiative for emergency and essential surgical care could do for the country. Well, we began to look at this laparoscopic thing, and she talked me into at least coming and trying it at the university. We set up our first course. In that first course, nobody got any long-term sustainable development because we had 45 surgeons come from around the country. They all wanted to get their hands on. We tried to do 6 gallbladders a day in 2 operating rooms. That was actually 12 gallbladders a day. By early evening, the nurses were gone, the anesthesiologists were gone, the chief of surgery was there watching all the instruments. We learned a lot of things on that first training group. The second week, we worked with a surgeon and taught colorectal surgery. We worked with one surgeon, transferred skills. He is now the premier laparoscopic colorectal surgeon in Mongolia, having done over 1,500 cases. So we began that program and started a project. She said, after we do this, I need you to go up to ErdNet. In fact, she had this project in her head that she dragged me into because I didn't have this concept. This looks really nice right now. But her concept was, I need you to go to ErdNet, Hovd, Abekir, and Choibosan, 4 of the main diagnostic treatment centers. There aren't roads in Mongolia. There's a lot of dirt roads. And she said, we need to have access to laparoscopic surgery. Our patients, 49% of them at that time lived a nomadic lifestyle and they couldn't afford to be sick. And so the Swanson Family Foundation, which is the one with the pink and the green, was the one who brought me. We partnered with the Mongolian National University there, and then we eventually started partnering with the University of Utah because we had a lot of people say, well, you shouldn't be doing this in Mongolia. You shouldn't be doing it in any developing country. You shouldn't teach laparoscopy. You need to teach basic surgery. And then SAGES that we brought in. And so the partners developed over time. It wasn't all at the same time. And so we did begin to look at, well, maybe people are right. Maybe we're teaching people just enough to be dangerous. So I asked some of our residents, were they interested? And they came over and began to do some of the projects. And we studied first from ErdNet and compared the outcomes where we taught there to the capital city where they've been doing it for 10 years. And after we followed that for a year and a half, found there was no difference in the outcomes. Now you have to remember that when I finished my residency program, I swore I would never write another paper or chapter or book or anything like that. I figured I needed to be a good father and I needed to be a good clinician. But the problems that we were being faced of people not understanding what we were talking about needed to be documented. And this is what kind of led us to develop some of this work. But it wasn't just the documentation of the procedures or the outcomes. We had to pull at people's heartstrings. And so we had to start deciding, how do we market what we are doing? So often we as surgeons, we put up a lot of data and, we have our glasses down and we can show you up in there the data that I'm looking at. And nobody cares. So how do we market it? How do we tell the story? We can do it through video. We can do it through pictures. We can do it through stories. This is a story that my wife came with me this year. I sent my resident, my anesthesiologist, and my nurse. Go get a Yunbayar story. We just operated on her. She's a 24-year-old mother of 2. She's the matriarch out there. Notice how many women are in that family right there. She's the one who really runs everything. This is her 4 days after her laparoscopic cholecystectomy. Milking her horses, making her cheese, making her yogurt, taking care of her family. This we were able to take the Ministry of Health and show them what was the importance for her and her country in terms of the effect of surgery on the community. We need to start thinking outside of the box how we tell our story. So this is another one that another partner, because ErdNet in 2009, we sat there and thought, well, we're teaching all these people in all these places, how do we get this into the residency program? And how do we train the faculty to train laparoscopic surgery? What are the skills they need? So we brought in the fundamentals of laparoscopic surgery kind of training program. And this is ErdNet in our course. ErdNet has become the president of the Mongolian Laparoscopic Surgical Society. He's become the director of the Laparoscopic Training Program at the Mongolian National University of Medical Sciences. And he says, Dr. Price, You know, as we ask him to do different things, he says, I know only 3 words in English. Yes, okay, no problem. I haven't had the heart to tell him that that's 4 words. But he tells me this every year I go. And remember the picture here over here on my left, you're right. This is the Zenescope that we're using there. It costs $85 to make. We'll talk about that here in just a second. But some of this follow-up work on what has happened in Mongolia with the partner that had like-minded ideas, like Erdene, we trained, and he then trained his teams, so that our teams taught in the maroon areas, his teams have taught in the blue areas. Laparoscopy is now available in 17 of 21 provinces, not because of what we did by ourselves, but because of their vision and what they did in finding like-minded partners. Here on my right, this is what happened. Open cholecystectomy just dramatically decreased. Laparoscopic surgery increased. It's up to about 80% now. This was 2013 at 60%. These are all the different courses of basic and advanced laparoscopic surgery that we had done at that time, both in the rural and the urban areas. It's important to document what you're doing. The Lancet Commission on Global Surgery. I've had an opportunity to be an advisor for that group. Suggest that they took 3 of the names that we suggested to be commissioners. Dr. Gonbold from Mongolia was one of these. Dr. Rodas was one of these. The Lancet Commission on Global Surgery estimates there's a $12 trillion loss to communities by 2030 in low and middle income countries if surgery is not addressed. But they also went on and took one of our early papers that showed this increase in surgical output. And they calculated that the total scale-up cost for 88 low and middle income countries to increase their surgical output by 8.9%, like in Mongolia, which actually turns out it was 17%. But 8.9% would cost about $300 to $420 billion, causing the Lancet Commission in Global Surgery to make this statement. Scale-up of surgical care should be viewed as an investment, not a cost. Can you see how finding like-minded partners, but then also incorporating appropriate research and data collection can actually have even a greater impact? So the third one, always keep trying. This one is probably the most important one because, as all of us can probably attest, it takes time and it takes effort, and you got to keep trying. This is from the Disease Control Priorities, 3rd edition, from the Essential Surgery book. In about 1990 or so, the first edition came out. There was nothing in surgery. In 2006, there was 1 chapter on surgery. And this one of the Disease Control Priorities by the World Bank had an entire volume on surgery. There's 9 volumes total, and surgery is incorporated in many of those other chapters. I would encourage you to take that, and you can download it for free as a PDF from the World Bank website, from the Disease Control Priorities website. This is a picture from that initial volume. And you can look at the range of services, quality, and access. And defining these 3 can really get us up to universal surgical coverage. Now, the blue area is if you have really all universal coverage for essential surgery. Now, there's sure a big debate. What does that mean? What does essential surgery mean? There's one group that says, well, there's 15 procedures. That's what it means. The Disease Control Priorities comes out and says, no, there's 44 procedures. There's another group that says there's 23 procedures. So there's a lot of debate as to what that blue box means. But that we are all excited about having the World Health Assembly recognize that emergency and essential surgical care should be part of, or is critical to universal health care. So it's taken us a long way to get surgery to where we are now with many years. Now, when I say keep trying, laparoscopy Mrs. Storch is not going to donate the millions of dollars to the rest of the world like she did in Mongolia. She was very nice. I went up to an American College of Surgeons meeting, talked to her, showed her what we were doing, and she says, what do you need? And she gave me every year exactly what I asked for. I'm sorry I didn't ask for more. But she is a wonderful lady who has a vision for the world. Unfortunately, 90% of the products and services that have been designed and engineered benefit only 10% of the world's population. So what do we do? When we look at laparoscopy, there's a 4.4 million laparoscopic surgeries done per year, and 7.5 million laparoscopic surgeries worldwide. The 4.4 is just in the United States. 90% of the cases are performed in the US and Europe, but there's about 30 to 50 million cases per year, additional unmet need in the developing market. So we say we have engineering and business students in here. This is where we need your help. So we did a couple things. We started a conference called the Extreme Affordability Conference at the University of Utah, partnering business with surgery, with public health, and with engineering. Asking the question, how do we get surgery more affordable around the world, even in our own country that needs to be fixed? Can you make things that are very expensive and make them for a lot less? At the same time, my son was dating a daughter of the dean of the engineering school. Find like-minded partners. Yeah, he thought we were coming to talk about his daughter and my son. I asked him, I said, can't you help us figure out how to do this? He sent me over to the head of the bioengineering department. Kind of blew me off for a little while until I told him about Jeff Tabin and their cataract surgery over in Nepal, where they designed a sutureless technique to put in this, the new lens. And they designed a new lens that cost $4 to make instead of the expensive lens. And then they set up a business in Nepal that mass produced those. And they compared them to the ones that put in the US, and there's no difference. And so now they're curing blindness all over Central and Southeast Asia, and now it's moving over to Africa. That's when he said, wait, what did you say? That was in the email. Wait, what did you say? Let's get together. And this has led to some exponential rise in products being developed in our Center for Medical Innovation and in our bench-to-bedside programs. One of these is the Zenescope. We had many projects looking at the light source, the camera, all sorts of everything. John Langell, who's now director of our Center for Medical Innovation, brought a lot of our students together and some of his ideas and developed the low-cost Zenescope, which is the laparoscope, the light source, and the camera. It connects to this little box, and that connects to an iPad. It can run for about 9 hours or 11 hours on battery. So it's now FDA approved as a single disposable device here in the United States. Costs about $85 to make just the laparoscope part. The little box is about $1,500, but it's reusable, so that's the reusable part. So they're thinking about selling that laparoscope for about $400, kind of like a stapler or something that you might use. Then you don't have the problems with infections, and you don't have problems with sterilization and those kinds of things. In Mongolia, we're using it about 25 times before it falls apart or becomes not usable. And they're actually collecting data on infections and collecting a lot of data. We hope to present at SAGES this year. My program manager, so why don't we broadcast this throughout the world when we do one of these from Mongolia? I said, that's the stupidest idea I've ever heard, next to Dr. Segerlin. How are we going to do that? We need to have internet capability. We have to have electricity that works well. That's when we called Dr. Erdene. Dr. Erdene said, yes, okay, no problem. And he ran the longest internet cord, for about a half a mile into the operating room, and we broadcast in virtual reality, 360 degrees. If you had the Google glasses or whatever, you could watch it and be right in the operating room with us. 44 countries watched it live. The Minister of Health watched it live, got so excited she took it over to the Prime Minister. How do we market what we do? Because the Minister of Health then said, we need to buy equipment for the rest of those provinces that don't have it. Wall Street Journal picked it up, did an article. This helps for getting other people to maybe donate to your cause. Well, this is just one of the things. We have many different products, one for cervical cancer, looking at carcinoma in situ. That if you can go in there and identify CIS with the little simple techniques, there's a little thermal regulator that you can put right on there. Then you can train nurses how to do this. You don't have to wait for pathology to come back. And you can treat really CIS early on. Cleft patch, hard to see what this is, but this little patch that goes on the patient, and on your phone, you can then read all the vital signs. And it's made very inexpensively. We have a program April 9th at the Capitol. There'll be 88 different projects that are presented. Companies are now showing up and buying the patents to a lot of things that are being developed. Many of these now, the exponential rise are for low-cost areas. So the best way to predict the future is to create it. That's what we all need to do. University of Utah is just like here. Imagine a place of possibilities. Now, we had to kind of fight for getting a Center for Global Surgery set up in 2011. It's about 2007 when we approached the Chief of Surgery and made the comment, I think we need to have a Center for Global Surgery. Catherine DeVries, who started International Volunteers in Urology, I was sent over to her because the Chief of Surgery said, go talk to Catherine DeVries. She does that touchy-feely stuff too. Wrong perception. What are we going to do here? So Catherine and I got together at her home, invited anybody, like-minded partners, to discuss what we could do. And one of the things that became painfully aware was we had to do some academic work. And I said, well, I promised I would never write another paper. But that's when some of that academic stuff started. We need to show that this is really academic. And we need to partner with engineering and business and these other groups. The university is a phenomenal place to be able to work together. Our Center for Global Surgery did finally get some funding when we went back and showed them what was possible. And our Center for Global Surgery, this is on a wall outside of our conference room, we define the problem. We explore solutions. We measure our impact. We train global leaders. We build surgical capacity through innovation, research, and advocacy. This is part of what we took back. This is now added to the Chief of Surgery, saying, look, we want to show you what's been done. One of the first books was the surgical care at the district hospital that the WHO did. But the next one really was our book on global surgery and public health, a new paradigm. John Miera's book on global surgery, the anesthesia manual, that we have chapters. We have chapters, or we've written the books in all these areas. The DCP3, the essential surgery. Our new book came out this last year, Global Surgery, the Essentials. And then finally, we're invited for Schwartz to write the first chapter on global surgery in a major university textbook. And the second edition, this is the 10th edition, the 11th edition has already been completed and should be coming out soon. We are gaining traction, and this is what we encourage all of our divisions now to work on, is not just to go and do the work. We need to be able to document what we're doing. So our Center for Global Surgery, as we try to reach out, we can't do everything for everybody, but we want to be available in places. We have a campus at the University of Utah, the Ensign College of Public Health, that was built by a family in Utah. It's now becoming a campus site for this formal site for the University of Utah. The University of Utah has a satellite campus in Seoul, Korea, in Incheon. And from these areas, we hope to reach out now further with our projects to Africa, both to Asia, and then also to the Americas. And so that as we grow within our department, so it's not just one person, two people, can we develop programs that can really outlast what we're doing, and we give people to fill these spots after we leave. So my program manager, my gosh, the best thing is to find anybody that's younger than 40 to help you. Have ideas that you've never thought of. And then our trauma surgeon, Jade Nunez, is over Asia, one of our emergency room physicians over the Americas. Marta McCrum, who worked in Boston as well, trauma surgeon, is over Africa. And Sam Finlayson, it's nice having a chairperson who speaks Chinese and wants to see our worldwide impact grow. Our Center for Global Surgery, divided up into Asia, the Americas, and Africa, have multiple projects that we're working on in the multiple divisions, from cardiac surgery to plastic surgery to ENT, pediatric ENT, emergency medicine, general surgery, developing educational programs, developing capacity. These are the things that we're trying to encourage through our program. This is one of the ones that we're currently working on in general surgery in Ghana as a breast cancer project. The top part here is what we found a surgeon in 2015 already beginning to work on in this area, where people present with stage 3 and stage 4 breast cancer. And it turns out 2 of my very good friends in that region ended up with breast cancer. One of them had been misdiagnosed, gone a year without treatment. She eventually ended up in my office in Salt Lake City, where we managed to facilitate her care. The other one didn't have the resources to come, and we managed to figure out how to do that there. Can we find a way that we can work at the very beginning to change how women perceive, or families, not just women, families perceive breast cancer so they present earlier? Can we improve the diagnostic capability? Can we improve the surgical capability as well as their chemotherapy? So we have gone back to the University of Utah and say, can we partner with the College of Public Health? They're starting a project this June, along with the College of Social Work. Our radiology department has already been over there to evaluate. We're working on trying to get a mammogram machine there. our surgery department, and even at Huntsman, our medical oncologists, all working on how we're going to try to work and see if we can find the answers that might be able to be broadcast so we can help other communities. This extreme affordability conference, I made the dumb suggestion this last year that maybe we should take it to the countries we're trying to help. And so we are doing that this year in July 8th through 10th. If you go online and look up extreme affordability, University of Utah, you'll be able to find ways to, we just put it up this last week, that you can submit abstracts. It's really to try to get ideas from the African nations, try to get their ideas for solutions in their own backyard. This is our meeting in Kumasi this last year as we're developing this with KNUST. So finding like-minded partners that like to push things further. Now I'm back to trauma, because about 5 years ago they said, you know, we actually do have a problem with trauma. Could you help us? And what we would like you to do is to help us bring the Advanced Trauma Life Support course to Mongolia. And I suggested, well, that's kind of expensive. I think here's some other possibilities. And they said, nope, we want the American College of Surgeons course. For the first time, Batsaihan, our coordinator, is coming to the international meeting. He's in San Antonio right now. I meet him there tomorrow morning. This is a picture of our first course in 2015. What's really cool about this, I want you to look at the partners. Michael Hollins from Australia, who was over Region 16 over this part of the world for the American College of Surgeons, said, let's make this a project that our region can do. So we went ahead and invited Advanced Trauma Life Support instructors already from that region, from Australia, Thailand, Malaysia, China, Singapore, and the United States, to partner together to move things forward out of their own countries into other countries. This is the guy with the blonde hair. He puts on this wig. He's from Singapore. They love him. He's great over there. We had some challenges. Nobody passed the course the first time we taught it. We found out the translation wasn't quite appropriate, and there's no word for translation for the word resuscitation. That made it a problem as you resuscitate people in ATLS. So we had to really make some adaptations, but currently we have 2 directors, 2 coordinators. We have 5 instructors, and we're certifying 6 more instructors in about 3 weeks when I go over for 2 more courses. In Mexico, the Mexican General Surgical Association and SAGES, we looked for a partner. I co-chair the SAGES Global Affairs Committee, and we had a very nice man show up and give us $500,000 to try to continue to do what we've been doing around the world in teaching laparoscopy. And we thought, how do we make that money go further? And we put out a request for RFPs for some ideas, and we didn't like any of them. People wanted to buy equipment. We said, no, we want to have an educational program. And we found the Mexican Surgical Association, and the president, past president, and the next president, all interested in trying to develop better education for minimally invasive surgery in Mexico. In fact, I should be in Mexico right now with the course that we had to move to this week, and I told them I couldn't go because I was coming here. But I've been getting tweets about their work there. This was a tweet I got. ILAP Orzabad Day 3, building a personal low-cost simulator at this course. I didn't have time to put in the picture that they're making from out of boxes, but we're teaching them how to teach with low-cost simulators, and they had a competition to try to develop the best low-cost simulator. Isn't that cool? That was the tweet I got last night. Can we make, instead of $1,000, something that's much cheaper? Boy, I have those backwards. The $1,000 one is the other one. The $75 one's over here. And this is the guy who's leading the course right now. He's probably going to be the president in about 3 years of the Mexican Surgical Association. If I knew 15 years ago what I learned at the SAGES Association Mexican Surgia General Surgery Educators course, I could have helped many more patients over my career. We actually went and had a 4-hour symposium along with the leaders of surgical education in Mexico at the Mexican Senate, trying to explain to the Mexican Senate the problems they have with their education programs in their country. The last 2 things I want to talk about, one is the World Health Assembly resolution. Now, many of you have probably heard about this, but how does a resolution like this get passed? It's a resolution that says strengthening emergency and essential surgical care and anesthesia is a component of universal health coverage. It was years ago that Adam Kushner called and said, Ray, we're not going to make any change in this world until the world decides that surgery is important. We need to get something passed at the United Nations. I got a lawyer. I've written up a resolution. He sent it to me. He says, you get Ecuador and Mongolia. I'll get Armenia and Nigeria. Boy, what a naive concept. So we started working on it. And so there's 30, as it comes to find out, Kathleen Casey, the previous Operation Giving Back before GIRMA, she went ahead and we got the American College of Surgeons to start looking at it. She looked up, there's a 36-member board of countries that can only bring the resolutions. So we had to get somebody interested, a like-minded partner, to take this up. And we got Ecuador and Mongolia and Nigeria all saying, oh, that's great, but nobody was willing to take the charge. And so we met with our US representative, and you know what they said? If this ever comes up, we're going to veto it. Why? Because we can't ask the WHO to put more money into anything. They don't have any money. It's a cash-strapped organization. I was chair of the American College of Surgeons, the governors from around the world. We put that on the agenda there and discussed it. One of the good things is coming to meetings like this and meeting people. So Pat Newman was becoming the new president of the American College of Surgeons. She came to our Utah chapter. We had a little poster competition, and one of the posters was one of my residents who went to Mongolia and did a project on that she really liked, and she awarded that the #1 prize. And then the chief of surgery said, could you give Dr. Newman a ride home? I said, I can, but I'm driving my lifted Jeep with its 35-inch tires. Can she get in it? She said, oh, she will. She loves traveling. So I got her in my big Jeep, and we went off driving, started talking about this problem. She says, that's ridiculous. We need to change that. So by 3 weeks later, we now have on all the agendas at the American College of Surgeons, at the Board of Governors meeting, the Board of Regents meeting, and at the International Surgical Presidents Society meeting, the concept of trying to get this resolution passed. We invited those from around the world to join with us and contact their representatives. We gave them a list of which countries were on that 36-member board. We got a letter approved by the American College of Surgeons. We was sent to our representative, and the representative said, thanks, but no thanks. So we sent another letter. And we got a sign-on letter, bipartisan, Democratic and Republican. Still struggling. I finally ran into Mike Leavitt at the airport. You know who Mike Leavitt was? He was the governor of the state of Utah, and then he was our Secretary of Health and Human Services for a few years. And I said, and he was also my kid's, use any kind of partner you can find. So I said, Mike, we're having trouble. We're having trouble with the United States. They're going to veto this. This is what we're trying to do. He said, Ray, you don't need the US. Get the African nations to come on board. And if they come on board, the US will look stupid and they will have to come on board. Now, there are many other people and working so many different things on trying to get this resolution, but that was one of the things that at the World Health Organization meeting for the Global Initiative for Emergency Central Surgical Care in Trinidad, Tobago, that's where Emmanuel Makasa came. That's where we began to tell him about the problem we were having. Who's Emmanuel Makasa? He's a general surgeon from Zambia who was over many of the African nations at the WHO. He says, this is stupid. We need to get this passed. He became our partner, and he became the leader that pushed this through. It takes time. You start small. You find the partners, and then you keep working on it. And that's how this became unanimously adopted by 194 nations. My last one is the, second to last slide, global surgery with the Lancet Commission on Global Surgery. You know, as we look at the work that has happened, the Lancet Commission on Global Surgery has been able to articulate so much of the data that had been collected. There was a group called the Burden of Surgical Disease Working Group that we had formed back in about 2005, 2006. It's what's become called the Alliance for Surgery and Anesthesia Presence Today, an organization within the International Surgical Society. That was a group that began developing a lot of the data that also the Lancet Commission on Global Surgery used. to articulate much better some of the ideas. And they had different indicators. These are indicators now that have been accepted by the World Health Organization and many of them by the World Bank, with various targets that we want to achieve. And we have many people from around the world working on these targets. You notice my talk has not been just about the Lancet Commission. This is an important concept. We need people working on these, but we need people doing all the things that have been talked about today that will help achieve these goals. Lastly, we've been working with Guillermo Tefera. We talked and said, we need to have a group of academic organizations that can partner together and work together to define some of the things that we talked about. Rachel's talk on this program here in Houston of the academic nature of a fellowship. What does it mean to be a global surgery fellow? Here's one group. Fantastic. There's another one's advocacy. There's another one's a totally research. What skills should people have? Can we define maybe some criteria that maybe would make it better for somebody when they finish a global surgery fellowship, they actually can be hired to go do something, not just in a foreign country. Maybe it's going to be an advocacy or policy or within the institutions here to make them a credible employee somewhere or partner. So this last October, we had our first meeting at the American College of Surgeons, inviting anybody from any academic institution that wanted to participate. We currently have now, Mamta Sarup is working with us out of Northwestern. We've developed a website that should be released fairly soon. We'll invite everybody in every program to begin to put their information in, that by the American College of Surgeons this fall, we hope to have a suggested set of vision and mission statements and bylaws to try to organize groups to help us build our academic centers for global surgery. Closing, I think this is a statement from Paul Farmer. As members of the world community, we must recognize that we can and should summon our collective resources to save the countless lives that were previously alleged to be beyond our help. And I can tell you, start small. Find like-minded partners. Okay? Thirdly, don't give up. Keep trying. I'm going to put forth at the very beginning, why do we go into this to begin with? Because we want to help people. And I would encourage us to remember why we do this. And if you think I know we've got a high school student here, you think you can't make any difference? Well, this is what the Dalai Lama would say. If you think you're too small to make a difference, try sleeping with a mosquito in the room. One of my worst nights of sleep was in Italy with one mosquito in the room that I could not find, but it would get in my ear all night long. What can you do to help the countless patients that you see to be able to see the shore and to give hope in whatever way we possibly can? Thank you very much for having me.
Thank you so much, Dr. Price. I think we have time for a couple of questions, if anybody has questions.
Like, when does the food come?
Yeah.
Sounds like I'm always worried about employment, but the fact of the matter is that people study for 12, 15, 18 years, or as many of us have done, and we don't see a place where we can get employed, then we're not probably going to go into that unless we are madly passionate about it. But there's a degree of the people that have interest and are less madly passionate that we may lose if we don't keep on the horizon some ability to be employed. And I think that you pointed out that World Health and World Surgery is actually changing, and there are places to be employed. And the other speaker, forgetting his name, the cardiac surgeon, stayed in the U.S. because he needed to do certain things and have an employment. But I think those are the things that when we're talking to the institutions, the administrators, to try to expand these programs and create positions for people in this room or people that are coming up.
You know, I think it was said very well earlier, get well trained. Become an expert in something. It takes about 10,000 hours. But it also was said earlier today, don't lose sight of your passion. And you don't have to wait your entire life to follow your passion, but find ways to make those join together.
Hi, my name is Gustav. I'm a research associate with Wolfhammer Programming, Global Surgery and Social Change back in Boston. And I'm working with John Muir and a set of other brilliant minds in establish, or they're working more with that, establish national surgical plans. That's something very much coming out of this WHO resolution. What do you think in general that the follow-through will be on this on a global scale for low and middle income countries? And in what kind of time frame will things happen?
Great, and he can probably answer that even better than I had, because John's working on it very hard. They've got a lot of different projects. We have Emmanuel Mikasa coming to speak at our Extreme Affordability Conference, really to address that for Africa and the progress they've made in Zambia, I think Tanzania and Ethiopia, some places that they're really moving forward. We've been working with National Surgical Planning in Mongolia and having some early discussions in Ghana. And there are different parts of national surgical planning that are there. There's, the Lancet has kind of defined a little bit more of what we'd like to see in a lot of those national surgical plans. But I think it's important to recognize that every country is a little different and what they're working on and what they need. And so that's what we're working on in Mongolia. They have some things in their surgical plan, or in their national healthcare plan. It doesn't look exactly like what we've defined, but still is there and it's growing. And I think it's just going to require a lot of people in the different areas, wherever we're working. That's something that can certainly be an advocacy effort. Every country, 194 countries, agreed to the things that are in that resolution. And it's something that surgeons can take and be able to bring that to the ministries of health. Say, look, you agreed to this, we can help you. How can we help you develop this surgical plan? I know we've got people working on it in Bolivia and other places. So I think it's going to be a long time. This is where it's going to be. We found like-minded partners. Now it's going to take a lot of work to keep it going. And just, how do you find like-minded partners? John Muir, the way I met him, I was down in Haiti, and he was working down in Haiti. And I had a lot of resources. And he just looked beat dead tired. He just looked, and he was standing there with his nurse. I said, what's going on? And he said, well, we've been waiting for 2 hours for a ride back so we can get a couple hours sleep so we can come back and keep operating. I said, well, I got a truck. Where do you have to go? I said, well, it's not, I said, I don't think it's too far. Well, why don't I give you a ride? An hour and a half later, but we had a great discussion in the back of that very hot, closed-in truck that has led to us becoming good friends for many years. So reach out to anybody you see. You may not know when it'll come back to help you. Thank you very much for letting me come.